Hello friends. Today's topic is use of albumin and diuretics in ICU. So the physiological effect of albumin. Albumin is natural protein that is produced exclusively in the liver in amount as high as 9 to 14 gram per day. The median half-life is 18 to 19 days. Albumin is responsible for maintaining the fluid balance between the intra and extracellular space. Albumin is also responsible for 90% of colloidal osmotic pressure. In critically ill patient, the interaction between colloidal osmotic pressure and albumin is complex and is significantly affected by increased capillary permeability and free capillary escape. The second property of albumin, it also has immunological effect. The role of cyclooxygenase derived icosanoid prostaglandin, that is PGE2. It is an immunosuppressive agent in patient with the liver cirrhosis. So the infusion of albumin will decrease the level of this PGE2, which may reduce the risk of infection in cirrhotic patients. So this is the diagrammatic representation of the interaction between endothelial cell, glycocalyx, albumin, and the interstitial space. The current understanding of vascular barrier function in high pressure segment of the vascular system includes the intact glycocalyx. So the intact glycocalyx barrier competence is preserved even at albumin concentration less than 10 gram per liter. So this green arrow demonstrates the colloidal oncotic pressure, keeping the fluid in the vascular lumen, while the blue arrow demonstrates the driving pressure out of the vessel, and thin purple arrow shows the trans capillary fluid flow, which results from the complex interaction of the endothelial cell, glycocalyx, and the albumin. So what is hypoalbuminemia? Hypoalbuminemia generally defined as serum albumin concentration less than 30 gram per dl, and it is a very common condition in the critically ill patient. So hypoalbuminemia leads to the increased capillary permeability with subsequent fluid distribution between the from the intravascular to interstitial space. So hypoalbuminemia, regardless of underlying mechanism, is associated with increased morbidity and mortality. At this time, there is no clear evidence to support the albumin replacement in critically ill patient with the low serum albumin levels. So we'll see what is the role of albumin in sepsis. Sepsis is the systemic response to the infection and it is a major cause of death in intensive care unit. It involves the immune dysfunction characterized by the simultaneous pro-inflammatory and anti-inflammatory responses, leading to the release of chemokines and pathogen-related molecules. So the use of albumin in sepsis presents the contrasting effect and is controversial. It is considered for the volume resuscitation in septic patients because of plasma volume expansion capability and potential to improve hemodynamic stability. So these are the evidences in the sepsis. So in 2004, SAFE trial was published, which compared 4% albumin versus 0.9% saline. And the outcome of the study was it had 28-day mortality and reduced vasopressor use in septic subgroup. So, and in 2011, the ERASE trial was published. It studied this. Again, it includes septic shock patient, which compared 20% albumin and 0.9% saline, and it showed there was no significant mortality difference. Then in 2014, Albios trial was published, which include the severe sepsis and septic shock patient, and it compared 20% albumin and crystalloid. And the outcome of the study was improved MAP and reduced heart rate, shorter time to the cessation of the vasopressor and inotropic agent, but there was no difference in new organ failure and there was no difference in mortality. Then in 2019, the RASP trial was published, which compared, which include septic cancer patient in the ICU, and it compared 4% albumin and ringer lactated solution, and there was no significant improvement in the mortality rates. So there were two trials which include cirrhotic patient with sepsis. So this is the FRISP trial and the ALEPS trial. FRISP trial published in 2021. It includes cirrhotic patient with sepsis-induced hypotension, and it compared 5% albumin with 0.9% saline. So, and the final outcome was there was a higher rate of hypotension reversal, sustained reduction in the heart rate, hyperlactemia, higher proportion of surviving patient at 1. Then in 2022, Ellipse trial published, which again compared cirrhotic patient with sepsis-induced hypotension, and it compared 20% albumin and plasma light. and it showed albumin was more effective and faster decline in uh, lactate. There was a reduced need of dialysis, longer time to dialysis initiation, similar 28-day mortality associated with the pulmonary complications. Now, the use of albumin in ARDS. As a septic patient, hypoalbuminemia in setting of ARDS is associated with the inferior outcome. So, albumin has many other properties in addition to its effect on the intravascular volume, including antioxidant activities and molecular transport. So there is an inverse association of the albumin concentration with level of several pro-inflammatory cytokines. In preclinical ARDS studies, the albumin attenuated lung damage by reducing oxidative stress and the pulmonary inflammation. So the hypooncotic albumin was associated with the renal dysfunction. So albumin improved oxygenation but did not affect the mortality in ARDS. So the albumin has the utility to inhibit platelet aggregation due to structural similarities between the two. In theory, therefore, in theory, albumin replacement may attenuate the coagulation cascade in ARDS, but administration at right time and right dose is important. So the albumin reduces the lung parenchyma, restores and maintains glycocalyx integrity in experimental ARDS. So the albumin, now we'll see the role of albumin in cirrhotic patient. In patient with the end-stage liver disease, albumin is often used as both medication or as volume replacement. The most supportive evidences for the use of albumin in patient with end-stage liver disease is available for fluid replacement after large volume paracentesis, that is more than 5 liter per more than 5 liters for patient with the hepatorenal syndrome and spontaneous bacterial peritonitis. Now there are various trials which was published in regard to this. So the first is answer trial, which compared the 40 gram of the albumin twice a week for 2 weeks, then 40 gram weekly versus placebo, and there was increased survival in the albumin arm. Match trial published in 2018, which compared the 40 gram every 2 weeks plus midodrine adjusted to the change in mean arterial pressure and matching placebo for 1 year. But in contrast to answer trial, there was no survival benefit between the two arms. Then in 2021, ATTAIR trial published, and the study included a hospitalized patient with decompensated cirrhosis who had serum albumin level of less than 30 gram per liter. Patients were designed to receive either targeted 20% albumin solution for 14 days or until till discharge. So this albumin infusion to increase the albumin level to target of 30 gram per liter or more was no more beneficial than the standard treatment. Now, in spontaneous bacterial peritonitis, it is typically appear in patient with the cirrhosis and ascites. Due to intestinal ischemia, the mucosal surface and intestinal epithelium was damaged, resulting into the bacterial translocation to the ascites. So these patients require the antibiotic treatment, and there is no surgical intervention is needed. Now, the evidence of the albumin in SPP. In 1999, the Sort et al. Published a study regarding the use of albumin in treatment of SBP. In this study, total 126 patients with cirrhosis and SBP were recruited either to receive the cefotaxime and albumin. So cefotaxime was given daily and albumin was given at a dose of 1.5 gram per kg of body weight at the time of diagnosis, followed by 1 gram per kg on day 3, and infection resolved in 94% of patients in cefotaxime group and 98% in albumin. However, ACAR developed in 21 patients in cefotaxime group, but only 6 patients in the albumin. So next is hepatorenal syndrome. It is a serious complication in patients with cirrhosis and is associated with the high morbidity and the mortality. It is characterized by the circulatory dysfunction that exceeds the compensatory mechanism of kidney, promoting vasoconstriction of the vas afferents, resulting into the decreased GFR. So the confirmed trial, confirmed trial was published in 2021. It is a phase 3 trial to confirm the efficacy and safety of terlipressin plus albumin in adult with the HRS1. Terlipressin plus albumin was more effective than placebo in improving renal function. Now, albumin in post-op patients. So, plasma albumin concentration was repeatedly measured over 72 hours. So, the plasma albumin concentration decreased rapidly from baseline until the start of surgical reconstruction. And the overall decrease in albumin continued until 1 hour after surgery, falling to 40% of initial value, was then stable for 72 hours. So, this pre-existing hypoalbuminemia would become more evident in this setting. So the hypoalbuminemia has shown to be associated with the inferior outcome in surgical patients. Now the conclusion of use of albumin. The 4% of albumin is hypoosmolar and should generally be avoided, particularly in patients with the intracranial pathology. The highest quality evidence exists for the use of albumin in patients with the cirrhosis, particularly in the treatment of SPP, HRS, and large volume paracentesis. In patients with the cirrhosis and hyponatremia scheduled for liver transplantation, they are at risk of osmotic demyelination syndrome post-operatively because of the rapid rise in serum sodium associated with the use of large volume of albumin solution. So the albumin formulation with the high sodium concentration should be avoided in this subgroup of the patient. For patients with the sepsis ARDS undergoing ECMO, the evidence of albumin therapy is not robust enough to allow for the general recommendation. And the albumin should be considered when hemodynamic stability cannot be achieved with crystalloid albumin. Now the next is diuretics. The commonly used diuretics in ICU are carbonic anhydrase inhibitor, osmotic diuretic, loop diuretic, distal convoluted tubule diuretics, that is thiazide and thiazide-like diuretic, distal potassium sparing agents, and vasopressin receptor antagonist. So this is the diagrammatic representation of the mechanism of action of different diuretics. Now, the first is a carbonic anhydrase inhibitor. So, the mechanism of action is carbonic anhydrase is the enzyme found in red blood cells and other tissues, including kidney. There are 14 isoforms have been identified, and two of which are fundamental in acid-base homeostasis by the kidney. Type 2, which is found in the cytoplasm of epithelial cells of the proximal tubule and in the intercalated cells of the distal part of the nephron. Type 4, which is found into the luminal and the basolateral portion of the cell membrane of the proximal cell, as well as thick portion of the ascending limb of the loop of Henle and intercalated cell. Its main action is in proximal tubule of the kidney, where it allows the reabsorption of bicarbonate, sodium, and chloride. So the carbonic anhydrase blocks the action of this enzyme. And the main example of this diuretic is acetazole. By inhibiting this enzyme, the main effect is that sodium bicarbonate is excreted along with excess water. In response, a reabsorption of ammonia occurs at more distal level, ultimately resulting in metabolic acidosis. So the diuretic effect is weak, but it can enhance the loop diuretic effect when used together, since the more sodium arrives in the thick ascending limb of the loop of Henle. Additionally, acetazolamide has intrinsic renal vasodilatory effect, protecting nephron against the ischemia reperfusion damage. It is known that the use of this diuretic generates tolerance when used for more than 48 hours and with decrease in the natriuresis. Thus, it is not recommended to use for more than 3 to 4 days per week or more than 2 consecutive days in order to sustain its desired diuretic properties. Now, the potential ICU indicator. In case of fluid overload, acetazolamide is used in combination with the loop diuretic is an option to explore. In diuresis CHF study, which included 34 acute heart failure patients on loop diuretic with fluid overload. The study found that addition of acetazolamide increased the natriuretic response to loop diuretic compared to increase in the loop diuretic dose. But there was non-significant trend towards the lower all-cause mortality or readmission for heart failure. On the contrary, acetazolamide use was associated with the trend towards higher decline in renal function during decongestive treatment. That is, it was observed that more than 0.3 mg per dl rise in serum creatinine was there within 72 hours. So the role in metabolic acidosis. In ICU setting, metabolic acidosis is common finding and it is associated with the worst outcome. So it is frequently iatrogenic owing to the administration of diuretics or steroid, and it result of permissive hypercapnia by lung protective strategies and chronic obstructive pulmonary disease patient. Therefore, apart from its potential use in the diuretic resistance, acetazolamide could be useful when metabolic alkalosis coexist, especially that caused by loop diuretics. Also, theoretically, by correcting metabolic alkalosis, it may increase the minute ventilation, improve oxygenation, which could facilitate weaning from from mechanical ventilation. So we can conclude that in ICU setting, acetazolamide could play a role in treatment of congestion, especially when high doses of loop diuretics are used and associated with metabolic alkalosis. In other contexts, such as COPD with mixed pH disorder, it could be considered when congestion is present. Now the adverse events are effects are acetazolamide may worsen hyponatremia, hypokalemia, and metabolic acidosis due to its mechanism of action. Patients who take acetazolamide on long-term basis, they are at increased risk of developing calcium phosphate lithiasis due to increased urinary pH and decrease in urinary citrate. They should not be the problem in ICU setting unless the patient already have a stone. Now the next is osmotic diuretic. The osmotic diuretics are freely filtered at glomerulus but poorly reabsorbed in the tube. So the mannitol is the main example of this group, and its mechanism of action is completely different from other diuretic agents as they do not directly interfere with the electrolyte reabsorption mechanism. In the proximal tubule and the loop of Henle, mannitol increases osmolarity. Consequently, the tubular fluid reabsorption is diminished. Furthermore, the other mechanism play a role in its diuretic action. Its hemodilution effect increases the total renal blood flow and at same time decreases the plasma colloid osmotic pressure, and it can increase the glomerular filtration rate. In addition, the role of mannitol as a protective agent in the AKI is based on the release of intrarenal vasodilating prostaglandins and natriuretic peptide, as well as on its oxygen-free radical scavenger properties. Now we'll see the ICU indication. One classical renal indication for the use of mannitol was the prevention of AKI because of its potential effect in the removal of obstructing tubular cast, dilution of nephrotoxic substances in the tubular fluid, and the reduction in the swelling of tubular element via osmotic extraction of the water. So mannitol has been recommended by some authors by the treatment and the prevention of rhabdomyolysis associated with AKI. Mannitol can be used in the prevention of ischemia reperfusion injury in kidney transplantation, and it showed the decrease in the incidence of AKI and the delayed graft function. The use of mannitol in the neurocritically ill patient is also common in the presence or for the prevention of intracranial hypertension. Now, the adverse effect of mannitol is high doses of mannitol are used, then it can cause hyperkalemia due to movement of potassium out of the cell. Now, the most common is the hypernatremia that we are commonly seeing in the ICU. It can result in the acute kidney injury due to renal vasoconstriction and tubular toxicity, and it can also precipitate pulmonary edema in the susceptible patients. Now, what is the role of osmolar gap when the patient is on the mannitol? So the during time of the mannitol is being administered, so plasma osmolarity and the osmolar gap, that is the difference between measured and the calculated serum osmolarity, should be monitored frequently. And we should discontinue the therapy if adequate diuresis is not achieved or if osmolar gap rises above 55 mmol per kg. Because of the other effects, such as immunological reaction with the various skin manifestations like toxic epidermal necrolysis, Stevens-Johnson syndrome, then hepatic toxicities like fulminant hepatitis, and the increased risk of encephalopathy, then it can cause anaphylaxis, blood dyscrasis. For all those reasons, its use is not recommended in patient with advanced liver disease and in patient with hyponatremia, hypokalemia, and metabolic acidosis. Now the next is loop diuretics. So furosemide is the diuretic of choice in more than 90% of cases of AKI with the fluid over. Now the mechanism of action. This loop diuretic will act on thick ascending limb of loop of Henle, and it blocks the secondary active transport of sodium potassium chloride channel out of the tubular lumen, and it produces the natriuresis that is accompanied by the diuresis. And this is associated with a greater loss of the water than sodium, resulting in the production of hypotonic urine. So, regarding administration and the dosage, there has been controversy about which strategy should be used, whether we should go for bolus or continuous infusion. So, they're saying that continuous infusion produces the less variability in peak plasma furosemide concentration, resulting into the consistent plasma drug concentration with more predictable diuretic effect. Theoretically, that could reduce diuretic resistance and also the side effects like dyselectremia and ototoxicity. So the RCT is mostly in the context of decompensated heart failure shows that there is no difference between the continuous infusion and the bolus of furosemide for all-cause mortality, length of hospital stay, electrolyte disturbances, but the continuous infusion is superior to the bolus administration with regard to the diuretic. So in this regard, in March, 3rd March and 2011, the dose trial was published, which was like diuretic strategies in patient with the acute decompensated heart failure. In that, loop diuretics was in this, as loop diuretics were essential, the component of therapy for patient with acute decompensated heart failure. So they have compared the continuous infusion versus the bolus dose. So, and the conclusion of this trial was in acute decompensated heart failure, there was no significant differences in patient with the global assessment of symptom or in change of the renal function when diuretic therapy was administered by bolus or continuous infusion. Now the next is furosemide stress test. A single center study evaluated the effect of utility of diuretic response to standardized dose of furosemide, and it was attempted to predict the progression of AKI and the need of RRT based on presence or absence of diuresis. So the patient with the stage 1 and stage 2 AKI were administered a standard dose of furosemide. Patients who were loop diuretic nil, that is, who were not on the loop diuretics before, they received 1 mg per kg of furosemide, while patient previously exposed to furosemide within the previous 7 days received 1.5 mg per kg of furosemide as the intravenous bolus. So the post-furosemide administration urine output was measured hourly for 6 hours and in total for 24 hours. So primary outcome was evaluated. That was the progression of ICAS stage 3 within 14 days of furosemide stress test. Now this is the pictorial representation of the furosemide stress test. That is 1 mg per kg of IV furosemide in those patients who haven't received furosemide, and 1.5 mg per kg, that is little higher dose in those patients who are already exposed to the furosemide. And urinary flow rate was observed in the first 2 hours. If it is a more than 200 ml, then it is a furosemide responsive. If it is a less than 200 ml, then it is a furosemide non-responsive. Now, Coiner et al. Compared the performance of this furosemide stress test to the multitude of biomarkers for predicting severity of AKI. So this biomarker did not perform significantly better than furosemide stress test for predicting progression to stage 3 AKI and the need of RRT not. So the conclusion line was the furosemide stress test seemed to be the good strategy to identify patients who may benefit from early RRT. When compared to furosemide, torsemide and bumetanide have more favorable pharmacokinetic profile because of their greater bioavailability, but their use is uncommon in ICU. Only one randomized clinical trial assessed the effect of torsemide versus furosemide on renal function in cardiac surgery patients recovering from AKI after continuous renal replacement therapy. And the both drugs were effective in increasing urine output, but torsemide showed better dose-dependent diuretic effect. As for patient with heart failure, there is evidence to support the use of torsemide over furosemide in non-hospitalized patients. Through additional anti-aldosterone properties, torsemide decreases the left ventricular remodeling, mortality, and hospitalization compared with the furosemide. Now, the next class of diuretic is distal convoluted tubule diuretics, that is thiazides and thiazide-like diuretics. Now, the mechanism of action is these drugs act on the distal convoluted tubule by blocking sodium chloride cotransporter, and it increases the excretion of sodium, chloride, and potassium. So there is increase in the calcium reabsorption in the distal tubule due to increase in the 3 sodium and the 2 chloride counter transporter of the basolateral membrane. So we'll see the potential ICU indications. So this diuretic family is most commonly used when the loop diuretic resistance is present in patient with fluid overload. And the presence of ICU-acquired hypernatremia is another theoretical potential indication in ICU setting. Now, the adverse effect is potential adverse event are related mainly to due to their electrolyte changes like hyponatremia, hypokalemia, metabolic alkalosis, and hypercalcemia secondary to its mechanism of action. In particular, attention should be paid to hyponatremia when thiazides are used in combination with the upstream diuretics. Attention should also be paid to allergic reaction as they also have cross reactivity with the sulfur. Now, the distal potassium sparing diuretic agent. This mechanism of action is this pharmacological group included those molecules that directly block sodium channel, which is amiloride and trimterene, and mineralocorticoid receptor antagonists, that is spironolactone and the eplerin. They act on the distal cells of the DCT connecting tubule and on the cortical portion of the collecting tubule, inhibiting sodium reabsorption through ENS sodium channel, causing decrease in sodium and potassium secretion by depolarizing negative luminal transepithelial gradient. So furthermore, amiloride and trimterene reduces the urinary excretion of calcium and magnesium. By acting at such a distal level where sodium reabsorption represents that do not need to be secreted into luminal portion of tubule to exert their action. So the potential ICU indications in the field of intensive care, these drugs are not used regularly due to their poor diuretic effect and risk of developing serious complications such as hyperkalemia. So the combination of this drug with the furosemide was actually associated with the reduction in 24-hour urine output with reduced risk of hypokalemia and without increasing incidence of hyperkalemia. So we can conclude that these drugs should not be used to treat congestion or prevent AKI, but could play a role when congestion is under control, but persistent hypokalemia exists due to other diuretics. Now, the adverse effect, the most frequent complication of this diuretic group is the development of hyperkalemia. This being dose dependent and with the higher risk of the patient with the CKD or those with the potassium supplements, angiotensin converting enzyme, angiotensin receptor blocker, anti-inflammatory drugs, beta blocker, heparin, and ketoconazole. It can also cause metabolic acidosis. Now, the amiloride and trimterene accumulate into the renal failure while trimterene accumulates in the liver cirrhosis patient. Thus, they should be avoided in such a scenarios. The noteworthy effect of the trimterene is that it can precipitate in the urinary collecting system and it cause obstruction at that time. Now, the next class of drug is vasopressin receptor antagonist. Vasopressin receptor antagonists act at the most distal level of the nephron, specifically by inhibiting the vasopressin 2 receptor of the principal cells of the collecting duct, which is responsible for the absorption of the free water. There are 3 receptors in the body for antidiuretic hormone and vasopressin. These molecules exert their action by competitively inhibiting these receptors. Like conivaptan will act on the V1A, V2, tolvaptan, mozavaptan, and lixivaptan act selectively on the V2 and has a more advantage of being administered orally. The only ones currently approved are conivaptan and tolvaptan. Now, the potential ICU indication, excluding euvolemic hyponatremia due to SIDH, which is not a focus of this review, is the main indication is hypervolemic hyponatremia refractory to the fluid restriction. And there is a lack of evidence in the ICU setting, but evidence in the hospitalized patient support its use to correct hyponatremia. So the loop diuretics may exacerbate sodium and water imbalance and worsen this hyponatremia. This salt now regarding the use of the tolvaptan, there are two evidences, that is solvent trial and the Everest trial. Regarding the solvent trial showed the tolvaptan was effective in increasing serum sodium concentration as well as urinary output at day 4 and 30. This mainly studied in hypervolemic and euvolemic hyponatremia. And the Everest trial showed tolvaptan had no effect on the long-term mortality and heart failure related morbidity. So we can conclude that tolvaptan can have a role in the treatment of fluid overload with hyponatremia, and it can improve the hyponatremia while urine output is increased. Now the adverse effects are mainly thirst, dry mouth, and polyuria. Then episode of ventricular tachycardia and can also cause liver damage. Now the newer class is the SGLT2 inhibitor and the gliflozins. Gliflozins are the novel class of antidiabetic drug that have demonstrated the great benefit in regarding cardiovascular and kidney protection as well as in the treatment of heart failure with or without diabetes. They act on the SGLT2 inhibitor located in the proximal tubule, which is responsible for the reabsorption of 90% of filtered glucose. So because of this, they promote glycosuria and thereby increase the urine osmolality, forcing osmotic effect and increasing by this way diuresis. So this is the site of action of SGLT2 inhibitor. Now, the ICU indication SGLT1 inhibitor is the novel treatment that its indication are restricted to the treatment of type 2 diabetes mellitus. More recently, it is also approved for the heart failure with reduced ejection fraction and preserved ejection fraction. Now, this is a trial which was published into the JAMA, which was like safety and efficacy of empagliflozin and diuretic use in patient with the heart failure and preserved ejection fraction. And the conclusion of this trial was this empagliflozin use was associated with the reduced diuretic use. Now, the next topic is the diuretic resistance. So, what is the diuretic resistance? So, diuretic resistance is the inadequate response to the diuretic therapy. It is failure to lose 0.5 to 1 kg of the weight per day when following measures are ensured. It is absence of third spacing, dietary salt restriction, and discontinuation of insulin. Now, how to overcome this diuretic resistance? So, the first measure is increased dose frequency of loop diuretic because most loop diuretics are short acting, and if we increase the dose frequency, it can help in overcoming the post diuretic sodium retention and restore the diuretic response. Then the next is diuretic substitution. This furosemide has the bioavailability of only 50% when torsemide and bumetanide have almost complete absorption, that is 80% to 100%. So if we replace the furosemide with the comparable doses of the bumetanide and torsemide, then it can be enough to improve diuresis. Then the next is by changing the route of administration, that is intravenous diuretic. Sometimes administering diuretic intravenously instead of orally is all that is needed to improve the diuresis. This oral absorption may be altered in the presence of gastrointestinal edema, gastroparesis, and delayed gastric emptying. So the drug concentration at the site of diuretic action of the tubular lumen may be inadequate due to decompensated heart failure, renal hypoperfusion, or impaired secretion as a result of hypoalbuminemia. Now, the next measure that we can follow is the sequential nephron blockage. A sequential sodium uptake blockage in different nephron segment by means of combination of two or more diuretics for different classes may produce additive or synergistic mechanism of action and diuretic response and can be effective approach in resistant cases. The use of loop diuretic, thiazide or thiazide-like diuretic with or without potassium sparing agent is most common in this practice. Now, which diuretic we can use in combination? So we can use the diuretic which are acting on the distal convoluted tubule like metalazone, which we can use it in the dose of 2.5 to 10 mg orally. Then hydrochlorothiazide we can use in the dose of 25 to 100 mg. Then chlorothiazide 500 to 1000 mg intravenously. Then diuretics which are acting on the proximal tubule, that is acetazolamide, and potassium sparing diuretics like spironolactone and amilorate. Then we can control, then the next major is the management of the intra-abdominal pressure. So if we manage to maintain this intra-abdominal pressure between 5 to 7, then it has a favorable outcome in improving diuretic resistance. Then the next is the infusion with the albumin. The simultaneous infusion of diuretic and albumin would slightly improve the diuretic resistance. And the other measures are use of hypotonic saline, renal dose of dopamine, and necessary. So this picture is showing the use of the diuretics in different scenario. This carbonic anhydrase inhibitor, it is mainly used when the metabolic alkalosis is present. Metabolic alkalosis is there. In different condition. That is a second option after thiazide in decompensated heart failure, and also used in the COPD with the mixed pH disorder. Then the thiazides are mainly used in the hyponatremia. The first option in decompensated heart failure. This vasopressin receptor antagonist like tolvaptan is also mainly used when there is a concomitant hyponatremia. Then distal potassium sparing diuretics are used when there is a persistent hypokalemia due to other diuretic use. Thank you.